I shall be talking about the preoperative radiological evaluation for the dorsal spine pathologies, and I'll take you through some series of cases through which I'll try to drive home the point of importance of radiological evaluation. So, as we all know, that normal thoracic spine has a thoracic kyphosis, and the cord is actually stretched over this thoracic spine. So there is limited mobility compared to the other part of the spine. The denticulate ligaments also hinges the cord to have some limited mobility. And the diameter of the spinal cord in the thoracic spine is comparatively larger compared to the thoracic spinal canal diameter. So all these factors play a role when there is a compression. So there is less reserve for the thoracic spinal cord. Also, there is an area of the watershed area in the mid-dorsal region where the cord is particularly sensitive. Also, there are regional differences as you go from the dorsolumbar junction to the cervicothoracic junction as well as the mid-dorsal spine. There are regional considerations, the level of the sternum, the watershed area. Everything has to be taken into consideration while planning surgical approaches to the dorsal spine. Also, something like this, tuberculosis of the spine involving the cervicothoracic junction, wet lesion, prevertebral abscess causing compression is different from what we see in a post-TB kyphosis like this, rigid, almost 100-degree kyphosis with cord stretched like a rubber band over the kyphosis. So all these cases have to be dealt differently compared to a standard one-size-fits-all approach. So radiological evaluation, obviously, as an academic institute with people in various levels of training, we always advise to get X-ray, CT, and MRI for every spine patient as a protocol. So X-ray, obviously, if there is obvious deformity like a collapse or a tuberculosis of the spine or a kyphosis, it's easier to pick. However, in cases like degenerative or where there are only subtle changes on X-ray, it may be missed. So difficult to pick unless you are an expert to pick it on X-ray. Some minor pathologies. That is why the importance of the same case in this is the case where there is some problem here. There is an osteophyte and which may be missed by a novice, but if you get a CT, you get to know that there is a big calcified disc which is causing compression. So that is the importance of a CT scan with a 3D reconstruction, and it's nowadays available in all centers, and it's very useful in planning. So it also gives the extent of calcification, how much it is extending, and the approach will be planned accordingly. Then the choice of approach, again, mainly the two approaches. One is the conventional posterior approach and the modifications thereof, like the posterolateral costotransversectomy, lateral extracavitary, and the other is the transthoracic approach. And the choice of approach depends on the location, the cervicothoracic junction, the mid-dorsal or the dorsolumbar junction. Then the pathology, whether it's a TB, degenerative, tumor, or deformity, whether it's a wet lesion or a dry lesion. And obviously, age of the patient and neurological status also plays a part in deciding which approach to decide. So like this, a trauma case, a dorsolumbar junction, pretty straightforward. Everybody will like to go posteriorly, do decompression, pedicle screw rod fixation, try to align the spine. So there is not much confusion. This case, a 2-year-old girl with a tuberculosis of the spine, power 3/5, a big prevertebral abscess and a compression and a kyphosis at the cervicothoracic junction. Obviously, the sternum is you can reach it anteriorly also, but it will be difficult. You may have to do a bit of sternotomy. In a small kid, it's a difficult thing, and obviously you will need a posterior correction. So what we did is actually, as you can see, the level of sternum determines where you can reach, and here you have to put a plate here, so probably you will have to nibble this much portion of the sternum, and that's difficult. That may be a difficult thing also in a small kid, and you all anyway have to supplement posteriorly. So what we did is actually uh, a posterior decompression and a posterolateral approach and decompression of the all the granulation tissue, and this is what was achieved after decompression and fixation. As you can see, the cage is well placed, the screws are well placed, and the alignment is corrected. The kyphosis from 38 it changed to 20 degree. So these are considerations. Even in kids, you should be thoughtful of what to do, and how much extensive approach needs to be done has to be decided. Then there are cases, similar case, similar location, but it's a plasmacytoma. So again, whether are we going to do a radical job, doing a complete spondylectomy sort of thing, or just do a posterior stabilization and give radiation and chemotherapy, because these tumors are very sensitive. So we decided to do just a posterior stabilization and send the patient for chemo radiation. So not all everything needs to be operated radically. So even tumor biology decides which will be the approach. Again, so another case of vertebral hemangioma, these 5-level ventral compression. If you were to operate this patient by radical vertebrectomy, it's a very, very difficult job, a lot of blood loss. And there is compression ventrally as well as laterally. And as you can see on the CT scan, there is honeycomb appearance. Another similar case of ventral as well as dorsal compression by hemangioma, and again compression, and which needs to be tackled. So what we did is an absolute alcohol injection and a short segment fixation, and it is a safer and less invasive approach. Just a short segment fixation and put alcohol, and the patient does well. And these are the follow-up scan of the same patient. The ventral epidural compression is gone. We did a laminectomy to make space for the cord, and this case, as you see in the follow-up, the compression is gone. So not every case requires a radical surgery. You have to decide depending on the characteristic of the pathology also. Then comes the degenerative pathology, very common in dorsal spine, and obviously difficult to treat. This is one case where there is a unilateral left-sided disc herniation, which is not calcified. It's a soft herniation, but there can be a spectrum. There can be a central disc herniation, which is non-calcified, and there can be a central disc herniation which can be dense calcified. Like in this case, as you can see, this is a dense calcification. The cord is actually hinged. These patients present with a variety of symptoms, right from myelopathy, and they are difficult to treat because the cord is actually hinged over a dense calcified disc. So what will be done for all these cases is actually, if it's a unilateral soft disc herniation, there is a transfacetal pedicle sparing approach which has been described. What it is actually is, this is the disc level and the herniation is somewhere here, and if you drill this facet joint, the inferior articular process of the facet, you will actually directly hit the offending disc. And since it's a pedicle sparing approach, it's not destabilizing, and dorsal spine is usually inherently stable. If you do an unilateral exposure and just do this drilling, you are actually, there is no need of fixation also. So unilateral soft disc herniation can be managed by this, and that's the importance of radiology with CT there is no calcification. On MRI there is a soft disc, unilateral. Then you may go ahead with this approach. So this is what I just described, that you just remove this inferior articular process, do a fenestration, and you're actually over the herniated disc. So no need of fixation. However, the situation changes if it's a central disc, because now you have to tackle the thecal sac, which is actually stretched over this. And if it's a calcified, then it's a different ballgame. So again, the central disc can be approached either by an anterior transthoracic approach or by a posterolateral lateral extracavitary or costotransversectomy approach. Obviously, the transthoracic approach has a learning curve, because not many people nowadays do transthoracic. So even the training institutes, very few people are now doing transthoracic. Most of them are doing posterior and posterolateral. So obviously, though transthoracic is a very elegant approach and a direct approach, many times people are not trained enough. At least the new ones, the old timers are definitely trained. And secondly, the transthoracic has its own disadvantages of thoracotomy and some restricted pulmonary function, which are though transient, but it is a morbidity. And posterolateral retropleural approaches are actually safe in that at least there are no pulmonary complication. So transthoracic again is a direct approach, as you can see, and a posterolateral approach right from the transpedicular, the costotransversectomy and LECA are progressively increasing exposure of the anterior structure. So and with minimum manipulation of the cord. So transpedicular will reach here, the costotransversectomy almost can reach the midline, and LECA can even go to the ventral aspect as well as to the beyond the midline. As you can see in this diagram also, the LECA can provide exposure almost till the opposite side and a very good decompression, and obviously the cord is preserved, but it will require progressively higher rib resection. So transthoracic can be approached compression, and there may not be a need for fixation, and even if you want to fix, you can put 2 body screws and a staple, and that is good enough, rather than doing a complete pedicle screw and rod fixation. It's a very short segment fixation if you need to do that at all. However, in the posterolateral approach, as you are removing the pedicle, the transverse process, and the LECA and the costotransversectomy almost always require fixation. So that is one con of a posterolateral approach. So this is one such case, a dorsally calcified disc approached by a LECA. You can see we did a fixation up front, and on the side which we want to approach, we removed the rib, the progressive exposure, the muscle, the rib, almost 9 centimeter of rib was resected, and then this is what is we are trying to drill the calcified disc, and this is the thecal sac. So this is how you reach the ventral surface of the cord without. This is what has been achieved post-op, and the patient did well. There are no deficit. Again, another case, kyphotic deformity with incomplete neurology. This patient has a kyphosis which is in the lower dorsal spine and 86-degree of kyphosis. In this case, we decided to do a transthoracic approach, as we thought that conus is stretched and we want a direct visualization of the conus, and this is what was the pre-operative reconstructed images, and this is a transthoracic approach. We did put a mesh cage and supplemented it with a posterior fixation. So from 86-degree, we corrected the kyphosis to 35 degrees. All the sagittal and coronal balance was corrected. This was the post-operative CT, well decompressed cord and well aligned. And these were the two incision, one transthoracic, one is a posterior midline. The kyphosis is gone. So you have to tailor your approach as per the patient as well as your convenience. And obviously, the patient outcome should be good. My approach doesn't matter. The patient outcome, if it is good, it's okay. Another case, this case is a rigid kyphosis. Just a point to tell, at times in lateral extracavitary approach, what happens is when you are doing this part of the drilling in a prone position, this is still a very difficult area to drill because you are actually, the cord is falling on your drill. Something like you can just imagine that the patient is lying prone and you are trying to drill an internal gibectomy from a posterolateral approach, and this area is very difficult. So if you do it in a lateral position, which is called as the lateral extrapleural approach. So this is the standard lateral extracavitary approach in prone position, where you are actually reaching here. But if you tilt the patient and make the patient lateral, your trajectory will actually be straight and the cord will be safe. So this is just one modification of a lateral extracavitary approach, which is a lateral extrapleural approach, which is usually done in lateral position, which is helpful in safeguarding patient. This is what is done in lateral position. And the same patient, we could correct almost 50 degree of kyphosis from 96 to 50. So to summarize, careful assessment of CT scan with 3D reconstruction and MRI are the prerequisite for any dorsal spine pathology preclinical evaluation, pre-surgical evaluation. Always check the soft and hard disk because the approach are different and the difficulty level encountered are different. Check whether it's a wet lesion or a dry lesion. Because dry lesions are difficult to treat, obviously that requires a lot of releases. Wet lesions are easier to correct. Check junctional areas and consideration thereof. Obviously the cervicothoracic junction, the level of sternum, how much anterior job, whether a sternotomy is needed, whether an access surgery is needed, everything needs to be done. Check the tumor characteristic like chemosensitivity, alternative treatment options like hemangioma. We have a good option in absolute alcohol with good long-term outcomes. So you should always think about, rather than the radical every case. Transthoracic is a very good technique, very elegant technique, direct access, better correction of kyphosis, better maintenance of alignment. However, there is a need for thoracotomy and complications thereof. However, and posterolateral is again a very versatile approach, and now you can do almost everything an anterior approach used to do from a posterolateral approach. And more people are conversant with this approach because of frequent exposures of the spine. And however, it needs fixation if you are doing pedicular resection and the extensive anterior job. So ultimately choose the approach which works best in your hands. All approaches are good. It's ultimately the patient safety which is most important. And thank you for your kind attention.